Picture this, you're in your MMI interview and the interviewer leans in and says, should GP practices be replaced with walk-in centres? How would you answer this question? Your mind would be racing. Do you talk about continuity of care? How can you integrate your own experiences into it? And then also talk about patient safety? In today's video, we'll be going through 10 NHS MMI interview stations. We'll be talking about how to break them down and also include your own insights and personal experience. Let's get started.
Station 1. Brexit impacts NHS recruitment. Analyse how the international medical graduates contribute to the NHS and the cultural challenges they may face.
So Brexit has had a big impact on the NHS. And first I'm going to explore the question in 3 different avenues. Firstly, how international medical graduates contribute. Secondly, the cultural barriers and differences that they might face. And finally, how best we can support them in the NHS to achieve the best patient care and also an ethos of teamwork, which is so valuable. So firstly, I read in a news article that international medical graduates can make up to 1/3 of all of the NHS workforce. Therefore, they're really essential for staffing and meeting the high demand for patient care that we need. In my own experiences volunteering, I noticed how international medical graduates can have a wide variety of skills and assets that some of the local graduates might not have. For example, they bring a wide variety of different languages, different cultural perspectives, which is really important for patient care. In my own volunteering experience in a GP practice, I noticed that one of the doctors that had come from a different country was able to speak the language of many of the patients in the local population. This really allowed them to feel valued and respected and reduce the need for services like interpreters. So it really shows that they can bring a lot of different skills. Talking a bit more about the cultural barriers that they might face, it's really important to acknowledge the isolation that international medical graduates face when they're journeying from their own country to the UK and trying to adapt to a system with established guidelines, communication, and also a different hospital structure and hierarchy. It also comes into the question about cultural differences in communication between different members of the team, and whether assertive communication or polite communication is more valued in a system. So it's really important, now moving on to talk about support, how we can best support international medical graduates to integrate well and also support holistic approach to patient care. So talking a bit more about the support, there's a multitude of ways we can try and best support international medical graduates. For example, setting up mentoring systems or buddying systems in which international medical graduates that come across can be paired with a more experienced colleague in the UK system that can advise them on the UK guidelines and communication and also cultural differences to ensure that patients are being respected, teams are being respected, and there's also an ethos of improved confidence and teamwork within the NHS, which is really valuable. So in conclusion, international medical graduates make up such a big proportion of the NHS workforce, and they're really vital for delivering diverse and teamwork-based patient care. It also brings a large variety of different skills and assets, which is really important to respect patients, especially when addressing how diverse the patient population is. And based on my own experiences volunteering, I understand how international medical graduates can communicate with the wide variety of diverse patients that we have in their own way and allow patients to feel most respected. So they really are a vital part of the NHS workforce.
Station 2. What is the role of the Medical Defence Union for NHS staff?
Yeah, so I can almost guarantee that almost every healthcare professional will have heard about the MDU. And in this question, I'm going to break down its responsibilities and why it's important. Firstly, talking a bit more about the guidance and advice it can provide, the legal protection, and finally, the education and training support it also gives. So firstly, talking a bit more about the guidance and advice perspective. The MDU publishes a lot of documents about documentation, consent, ethical decision making, and how to operate when it comes to complex medical legal cases. So this can help clinicians feel more confident and reflect on ethical decision making and help them to feel more empowered to make complex decisions with the safety net of having the MDU guidance there in place. It's also really important for providing legal protection. It offers clinicians indemnity if claims are made by patients or regulatory bodies. It doesn't, however, take away from professional responsibility, and it doesn't guarantee immunity either. So it's really important that clinicians are aware of their own limitations in decision making and able to reflect on complex patient decisions and ensure that they still have that clinical responsibility. So it doesn't act as a shield from that. And finally, talking a bit more about the educational support it gives. So in my own school experience, I understand the value of having structured guidance in order to reflect on mistakes and work forward. And the MDU often sponsors a lot of training events and workshops which can help to reinforce the awareness of the MDU in clinicians' minds, and also help them to deliver more workshops and presentations and develop the clinicians' understanding of how they operate and the safety net that's available to them, and help them feel more confident in making complex decision making. And in turn, that's how the MDU helps to protect patients and support care. So in conclusion, the MDU can help to act as a safety net for doctors. It doesn't eliminate professional responsibility, it doesn't guarantee immunity, however, it is a safety net that's present for them to help confidence when making complex decisions, and also in turn help patient care and also further patient care and decision making.
Station 3. Medicine consists of lifelong learning. How do doctors in the NHS engage with continuous education?
So medicine is an ever-changing field with so many different advancements, and it's really important that doctors stay on top with those new advancements to enable good patient decision-making and treatment plans. So doctors are expected to have continuous professional development throughout their career, and I'm going to outline 3 main ways they do this in my answer. Firstly, about formal teaching and also attending conferences and research. Secondly, about reflection, and thirdly, about learning on the job and mentorship. So firstly, doctors of all stages in their career are expected to attend workshops, courses, training events, and also conferences in order to build on their knowledge and learn more about their specialities and what's new in the field. They're also expected to attend these events to maintain their GMC registration, constantly evaluate their continuous professional development to enable good patient decision making and holistic care for their patients that's up to date and relevant. Now, talking a bit more about my own volunteering experience, I noticed that when I was volunteering in hospital on the wards, I noticed that doctors were continuously conducting research and audits in their respective specialities, which really helped to inform their own knowledge about their specialty and up-to-date clinical guidelines and practice. I also noticed that doctors are often away at different conferences or attending training events with other staff helping to support the gaps in staffing. So having that research focus or development focus is really important within the NHS. Secondly, talking a bit more about reflection. Reflection is always consistently talked about from medical school all the way up to consultancy, and it's really important to reflect on mistakes that have been made and how you can improve for the similar situations in the future. When I was shadowing in general practice, the doctors often come together with other healthcare professionals and reflect on their own decision making, how things might have gone wrong, and what could go better for consultations in the future. So reflection is a really useful tool for continuous professional development. And lastly, talking a bit more about learning on the job, consultants and doctors of all grades are facing different patients every single day, and every patient provides a unique learning opportunity. Doctors are also expected to engage with mentoring, for example, medical students and younger registrars or other doctors where consultants are expected to take on that responsibility. And when you're able to teach something, that allows you to develop your own understanding of the different conditions in your specialty and how it's advanced with different research and how the clinical guidelines might have changed recently. So in conclusion, formal teaching opportunities in training, reflection, and also learning on the job from both patients and mentoring can really help to develop the continuous professional development and allow doctors to remain up to date, allow them to stay curious about their specialties, and allow to build up their skill base to be good, effective clinicians to optimise patient care.
Station 4. What are the additional pressures faced by the NHS during bank holiday weekends?
Bank holiday weekends are typically something that everyone looks forward to, having some time off, some time with the family. However, for the NHS, it can be a very different situation. It can be a very challenging situation for doctors and other healthcare professionals to work around. This is due to a multitude of different reasons I'm going to explore more in my answer. Firstly, about staff shortages. Secondly, about a surge in patient demand for the services, and also limited service and resources being available. So firstly, talking a bit more about staff shortages. A lot in the bank holiday periods, a lot of staff like to take those days off or reserve those days for family and other events or situations, and therefore it can leave the NHS services being much more stretched, and can also be a bit more tense as on-call teams over bank staff can be used instead of the usual team, so it can disrupt team dynamics a bit more and lead to a lot of increased requirement for communication and flexibility. So those skills are really important to navigate those situations and ensure that patient care is still being met, particularly in emergency situations. Secondly, in those periods there tends to be a surge in patient demand for the services. Some patients do typically delay going to the GP for when they have a bank holiday weekend or some time off, due to having very busy work schedules normally. However, this does put additional strain on the services combined with the staff shortages that I just talked about. Also, I've read in some news articles that there's also tends to be a surge in admissions to hospital, particularly emergencies in the bank holiday period, like accidents, alcohol-related injuries and trauma also surges in those bank holiday periods. So that's something that's really important to bear in mind and can put additional strain on those services. And lastly, elective procedures, routine appointments can sometimes get cancelled over the bank holiday period, and therefore there can be a knock-on impact on patient care and also lead to some emergency presentations at times, or if elective procedures are getting cancelled, it also poses a lot of strain on the NHS and a strain on those patient resources as well. So in conclusion, reflecting on the bank holiday period, it's really important that clinicians demonstrate good communication, teamwork and flexibility, working with temporary teams that they might not have worked with before to meet staffing shortages, dealing with a surge in patient admissions for a multitude of different reasons related to the bank holiday period, and finally about elective procedures getting cancelled, routine appointments getting cancelled, and trying to meet the challenges associated with that.
Station 5. Patients are encouraged to use NHS services wisely during strikes. How can healthcare providers educate the public on efficient healthcare usages?
Yeah, so patients are encouraged to use NHS services wisely during times like strikes, and healthcare providers have a key responsibility in educating the public. So I'm going to look at this in three main ways: through clear communication, community outreach and preventative education, and finally about using technology to help educate the public more as well. So firstly, talking a bit more about clear communication, healthcare providers can provide leaflets, talks, workshops on how to educate the public when it's best to use A&E, GP and pharmacy services. This can help to educate the public on when to use the right services at the right time and reduce unnecessary strain. When I was shadowing in general practice, I noticed how GPs tend to have a safeguarding or safety netting situation where they explain to patients when to seek A&E care if their symptoms worsen in particular, and then what kind of symptoms that they can manage their own at home. This is really effective to ensure that patients know when to access the right care and help to reduce that strain of attending hospital when they really didn't need to. Talking a bit more about community outreach and preventative education, healthcare providers can deliver talks in schools and talks to parents about how to look after their child and how about nutrition, caring for minor treatment or injuries to help to reduce that strain on A&E services, particularly when dealing with those minor injuries that can be looked after at home, and reducing exposure to viruses and other things that you can get in hospital as well, which helps to reduce the strain on the NHS, but also helps to ensure that patients are being able to have self-care of their own ailments and be able to reduce the risk of infections that they might acquire from hospitals as well. And finally, it's really important that we talk to patients about the apps available, online resources that they can help and utilise, including symptom checkers, which help to allow them to differentiate between something that might need an emergency admission or things that can be looked after at home. In my own wider research and GP shadowing experience, I noticed how GPs often talk about how to use the NHS apps and resources. There are symptom checkers online which can help patients feel more empowered to take their healthcare into their own hands and know when they might need to escalate their care into A&E or an emergency admission. So in conclusion, during strikes or challenging times for the NHS, public education is really important of when they should attend emergency services, when they should access GP services, and it can really help to reduce strain on the resources if they know when the symptoms might warrant emergency admission and when things might be better to be taken care of at home.
Station 6. The NHS was founded to meet the needs of everyone, be free at the point of delivery and be based on clinical need. Are these principles still upheld today?
Yes, there's been a lot of debate about whether the NHS principles are still being upheld today. So today I'm going to explore the key principles of the NHS. Firstly, meeting the needs of everyone, being free at the point of delivery and based on clinical need, and how the values are upheld today and some of the challenges that we're facing in the NHS. So firstly, talking a bit more about meeting the needs of everyone, the NHS has been under a lot of pressure recently with staffing shortages, financial restraints, and also difficulties with funding and resource allocations, which means that patients can be left with very long waiting lists, feeling frustrated and having to turn to other service usage, for example, the private sector. This can widen gaps between accessibility and healthcare and really make it difficult to support the principle that it's meeting the needs of everyone. However, there have been implementations, for example, having an online booking systems for appointments, which help to try and improve that accessibility and mean that it's available for everyone. Secondly, about it being free at the point of delivery. Yes, the NHS to this day is still free at the point of delivery for everyone. However, there's also a lot of hidden costs which aren't evaluated. For example, travel costs of trying to get to a hospital, prescription costs, and also some people having to turn to the private sector due to the long waiting lists. So these kinds of factors can often be forgotten, which means that the NHS principle of being free at the point of delivery can sometimes be a bit murky, and it's difficult to see where it applies in some of the more complex cases with longer waiting lists. However, as I mentioned, when I was shadowing in my own GP experience, I noticed how GPs often advise patients to look at the online booking system appointment, NHS apps, and a lot of telemedicine and technological advancements help to promote the free delivery ethos of the NHS and help to support patient accessibility that way. And finally, the NHS being based on clinical need, that value is very much still upheld, particularly in the emergency department. When I was volunteering in the triage area, I noticed how patients were always triaged based on their clinical urgency, not about their financial situation, not about their age or status. So I think that's really reassuring. And seeing how the NHS team, for example, upholds values of teamwork, communication, and flexibility with trying to prioritise emergency admissions really demonstrates the fact that the NHS is still able to uphold that key principle. So in conclusion, the NHS principles of being free at the point of delivery, meeting the needs of everyone, and also being based on clinical need is very much still upheld. However, due to limitations like staffing shortages, funding problems, and also resource limitations, those values can be tested. However, it's really important that staff are able to have improved communication, good teamwork and flexibility to try and uphold that values in a high pressure environment as much as possible, and uphold that values to improve patient care.
Station 7. What are the benefits and drawbacks of using a GP gateway system to access specialist services?
So in the UK, we have the GP gateway system, which is in place to allow patients to access secondary services through first attending the primary service and being referred to those secondary specialist platforms. So it's beneficial in a multitude of different ways. So firstly, it's about providing continuity of care for patients. It's also about ensuring that only the most important cases get referred on to specialist care, and that primary issues can be managed more in a GP setting. And lastly, it's about ensuring that resources are being used effectively. So firstly, talking a bit more about the continuity of care, I've noticed that a lot of patients in hospital, when they had been referred through the GP pathway, had more of a coordinated care picture, and they felt reassured and comforted with the fact that hospital professionals weren't having to ask for their history over and over again because the general practitioner had coordinated that referral, so that was already in place. So it can really help to grow that continuity of care for the patient and bring that extra patient satisfaction with the system. Secondly, talking a bit more about having that extra step in place, which helps to ensure that all of the more non-urgent cases can be managed in the primary sector, and so that more urgent cases can be prioritised for hospital care. For example, when I was shadowing in general practice, I noticed that a patient had come in with a swollen knee. Ultimately, it wasn't a serious condition that needed to be referred on to orthopaedics, and the GP was able to refer the patient to physiotherapy due to an overuse injury. So it helps to ensure that the specialist service is only being used for those really important cases, and that GP and family medicine is being used for what it should be used for, being able to deal with more of the non-urgent cases and referring on to the appropriate intervention for the patient. Also, lastly, talking about the resource implications, having that extra step in place where patients are able to attend the GP practice and be seen often more quickly and have their needs prioritised and directed to the appropriate service. For example, physiotherapy or social prescribing can really help to reduce the limitations placed on the hospital services, where emergency departments can often be really understaffed and have a really high demand of patients. So it reduces that risk of the patient needing to be admitted as well, and the infections they might be exposed to in more of the hospital environment. Now talking a bit more about the drawbacks of the GP practice and having that gateway system before you're able to see a specialist. Firstly, the GPs may miss some subtle signs of conditions, which can lead to delayed presentations of serious pathology to those specialist services, so that's always a risk. The second thing, having that extra care in place can sometimes be frustrating for patients as well, when they feel like they would really rather see a specialist who knows all about a particular area that they're worried about. So sometimes patients can be more concerned about that. That, however, is a really important conversation that a GP can have with a patient about how they could be a good first step to evaluate the problem, and a hospital consultation referral may not be necessary for the problem that they're dealing with. And finally, having that extra step in place from the GP practice to access secondary services can also also delay presentations. Patients may find it difficult to find a GP appointment, especially in the current climate with the GP appointment shortage, and having that extra step in place before you're able to see a secondary specialist can delay treatment of urgent conditions and can also lead to progression. So that's a risk that we also need to evaluate when we're discussing the benefits and drawbacks of having a system like our own. So in conclusion, having the GP gateway system is really important for patients to be able to see a private specialist to see if the issue is more non-urgent or urgent and be referred to the appropriate secondary specialist as well. So that's why we have that sort of system in place, and it also ensures that patients are not accessing secondary services without having the clinical need to. It helps to relieve the resource limitations on those services as well. It also helps to promote patient satisfaction, because if they are required to be referred on to secondary, you have a long continuous patient support plan in place by the GP and continuous GP involvement in their care plan. So it helps to ensure that hospital clinicians are aware of the situation and the GP background behind it, and the GP is also updated about what the patient's going through that coordinated referral process.
Station 8. Should primary care services be replaced by more walk-in centres?
So imagine on a Monday morning you're feeling a bit unwell and you're not really sure whether you should go to your GP or you can go to a walk-in centre where you can get the issue fixed much faster. So in order to answer this question, I'm going to be balancing arguments for walk-in centres against walk-in centres and why primary care really does matter. So firstly, some of the arguments for walk-in centres: it's a really fast way that patients can get the care that they need in the moment, particularly for more of the non-urgent cases. For example, having prescription changes or needing advice about having like a common cold, something like that. It reduces the need to having to book appointments long in advance, as there's a very big reduction in GP booking services, and it also helps to relieve the strain on general practice as well. Secondly, it can also be a lot more convenient for patients to access the walk-in services. As I mentioned, with the lack of availability of GP bookings and also having to journey to wherever the GP practice is, sometimes having those walk-in centres available where you can just walk in, have a quick solution for a cold or any common ailment can be really beneficial for patients and also help to alleviate that strain, as I mentioned. When I was shadowing a GP practice, I noticed how a lot of the GP's consultation evolved around having to treat common colds, investigating viral illnesses which are often self-limiting and may not require urgent treatment or like prescription of any antibiotics or other things like that. So I noticed how having those walk-in centres available, signposting patients to those walk-in services might be more effective. It means that they don't have to wait for having a GP appointment and allows them to get the care that they need in a much faster time, especially for those non-urgent cases. However, now for the more arguments against and why primary care really is essential. GPs provide you with continuity of care, which walk-in centres really cannot provide you with. GPs can assess how a patient's feeling based on the way they walk into a consultation, the way they're talking, and how subtle changes in their behaviour based on previous consultations might indicate that something's wrong and also prompt that referral to secondary care that the patient really needs. So in a walk-in centre where you might be seeing one doctor once that you haven't seen before and you don't have that level of continuity, having those referral processes in place or understanding the patient's whole background is lost, which is a really important factor to ensure that the patient gets the best care that they need. The GP practices are also essential for complex decision making. For example, with patients with chronic conditions, it's often much better to have that managed in a GP setting where you're able to follow up the patient journey and how different treatments might have worked and other treatments might not have worked, with the walk-in centres might not have that background available. So reflecting on both arguments for and against, it's really essential that GP practices are given the attention that they deserve. They are really important for continuity of care, referral to secondary services, and are the first point of care that a lot of patients feel comfortable going to, where the GP really does know your background and your story. However, walk-in centres really do have a good place and they should be used to complement primary care, not to replace it. So having the urgent treatment that patients often need if they have a common cold, some non-urgent requests like any prescription changes or evaluating other like common injuries, things like that. Those are some of the facilities or some of the complaints that walk-in centres would be really well suited to dealing with compared with the GP practice, and also ease some of that tension placed on the GP services.
Station 9. What is your understanding of quaternary care in the NHS?
In a nutshell, quaternary care is essentially the very niche, ultra-specialised high care service particularly for complex, centralised, very rare diseases. So essentially we all know about how general practice is more the primary care, secondary care is more hospital care, and tertiary care is a bit of a blend of more specialist services offered in a typical hospital environment. Quaternary care is the next step up with the ultra recent technological advancements like surgical technique, and also management, diagnosis and treatment of very rare conditions. So quaternary services are often just a handful of hospitals dotted around the country and often have patients from all up and down the country referred onto those services. So now talking a bit more about the key factors behind quaternary care. Firstly, it allows the provision of care for very rare conditions that you wouldn't be able to get treated otherwise in tertiary services. So it allows patients with those rare conditions to be able to be investigated appropriately, allows rare cancers to be receiving the treatment that they require, and also advancement in surgical techniques. For example, when I was volunteering in a hospital, I saw that there was often quaternary care referral criteria on posters in the cardiology ward. So it allowed doctors to be aware of when to refer their patients onto a quaternary service so that their patients can have the best chance to benefit from the most recent and up-to-date technology for those more rare conditions that can't be managed appropriately at the tertiary care level or the secondary care level. Also talking a bit more about research, quaternary services are often at the forefront of all research because they have the most advanced technology, they're constantly evaluating their surgical technique and sharing their expertise with other services around the country, and they also have a very big insight into research, particularly for those genetic conditions which do tend to be under-researched because they're seeing such a large group of those rare conditions in one place, so they're able to study the pathology and epidemiology appropriately. And lastly, why they matter. Quaternary service, as I mentioned, allows patients to be referred and escalated appropriately onto the services that they need. So if you're a patient with a rare genetic condition, you are able to be treated by specialists in that area that have seen other patients like you and know how to respond to your situation and escalate your treatment appropriately. It also ensures that tertiary services or secondary services are not overwhelmed with difficult, complex conditions that they don't know how to manage, and they're aware of the ability to escalate to those quaternary services on a national level, which allows patients to be seen in the way that they deserve and have that holistic treatment approach.
Station 10. Should the NHS provide a 3-month shadowing scheme for prospective medical students?
Imagine having the opportunity to shadow in a hospital or GP practice for 3 months. I was able to shadow a week in my own volunteering experience, and it already helped to demystify healthcare, boost my confidence, and also help me develop more practical skills like communication and teamwork. Having that 3-month period could be brilliant to try and understand more about the role of a healthcare professional and understand whether medicine is the career for me. But first in my answer, I'm going to first talk about the benefits and then talk about why it might be a bit more difficult to organise an experience like that. Firstly, it's important to recognise the fact that if we have a 3-month placement, it could really help to confirm whether medicine is the right career for us. It allows us to see patients day to day, see what the role of a doctor entails across a multitude of different specialties, and also helps us to understand more about the role of other healthcare professionals and whether maybe another healthcare professional role might be more suited to what we want to get out of our career in the future. Secondly, having that experience gives us a real insight into what medicine is all about, and the fact that it's not just about science, but it's mostly day-to-day communication with others and how research might also impact on the way patient care is delivered. And having a 3-month period is going to be much more beneficial than having just a 1-week limited exposure. Now talking a bit more about the drawbacks. Firstly, having a long 3-month period organised could be very difficult logistically. As high school students, we know that we don't really have a very long period over summer, and it's definitely not an extended 3-month period. If we're trying to find time when we could organise something like this, would take time out of our school commitments, extracurriculars, and other school-related projects. So it's really important to understand the implications that organising a 3-month experience might have on those factors in our lives. Secondly, it's also important to consider the supervising constraints and restrictions. For example, if you have aspiring medical students in hospital trying to gain mentorship and experiences in the hospital setting, it might take away from the medical students teaching, which is really important because they're ultimately training to be the next doctors and they're in the middle of their training, so it's really important that they're getting the prioritization that they deserve, and ensuring that aspiring medical students are not being ignored in that process could be a really tricky situation to navigate. And finally, Having longer extended hospital placements might be more difficult for the hospitals to organise, and they might be more inclined to offer like shorter placements, like logistically, and be able to support the student for that shorter period of time as opposed to longer extended period of time. And also students might find it really difficult to localise those opportunities if they're in a more rural setting where there's less hospitals available, compared with a more urban setting where there might be more opportunities available and more insight into like the rarer specialities. So that could also perpetuate like discrimination and accessibility between hospital services, and it might be more difficult to navigate aspiring medical students' experiences when one has had extensive experience in an urban setting in hospitals and one has much more limited experience in a rural setting as they weren't able to secure a 3-month placement. So in conclusion, having a 3-month placement would be amazing to try and like demystify healthcare, to boost our confidence and gain those practical skills before we even start medical school. However, it would be logistically challenging to organise a fixed 3-month placement. It might be difficult for some students being able to access opportunities to have a 3-month placement, while others are not able to have that luxury as they might be in a more rural setting with less access to hospitals. And finally, having the supervision constraints, for example, medical students will need to be prioritised. It might be difficult to ensure that aspiring medical students are getting the attention that they also deserve in those situations. So ultimately, it might be a decision that we need to think more about breaking that 3 months down into maybe like smaller 2-week periods where students can like volunteer in their holidays as opposed to taking time out of their school or other commitments. So it's an important thing that we should be thinking about more. That's all, everyone. Thank you so much for watching the video. I really hope you found it was useful. Sometimes it's just helpful to go through those kind of NHS-based stations. All of the examples I was using are just some like volunteering examples of what you could relate on your own personal experience, but it's really important to reflect on the own experience that you've had, whether it be part-time jobs, hospital volunteering, or your wider reading, and able to include that in your own answers and reflect on that appropriately. If you did like the video, be sure to subscribe and drop us a comment to share your own MMI interview experiences, or if you have any questions for us at all. Stay tuned for our next videos where we will be going through more interview style questions to try and get you to ace your MMI interviews. Thank you all for watching.